Hello to everyone and welcome back to my channel. My name is Tommy. I am a human nutrition student and researcher at the university. What I do in this type of videos is to synthesize the classes at the university and then I explain and teach you the best and most valuable information you need to know. Today we're going to continue the clinical nutrition series of videos and we're going to talk about obesity. A very important topic. So let's begin. Obesity. It is a disease not yet understood that creates adipose and cerebral dysfunction. We say that the BMI over 30 is not enough to determine obesity. An example is that The Rock has a very high BMI, but he is jacked, not obese, because muscle weighs more than fat. So we have to phenotype obesity, abdominal adiposity, bioimpedance, and defining the comorbidities. It is correlated with the metabolic syndrome, which we saw in the last video. The first cause of preventable death after smoking. Obesity is associated with cancer. If we lower the weight by 10% when we are obese, we also decrease the death rate and the comorbidities. And here, with these patients, we have to talk about gaining health and not losing weight. Physiopathology, we have three main factors here that determine the occurrence of obesity. Genes and environment, physical activity and exercise, and of course, dietary habits and composition of the diet. In the genes and environment, well, we have the polygenic obesity, which is the normal human obesity, the monogenic obesity, which is a single gene mutation, and the pleiotropic dysmorphic syndromes, physical and developmental abnormalities. Then, leptin. Leptin is very important. It is the satiety hormone, and a deficiency is associated with obesity. If you're not satiated, you're going to continue eating. Environment. Epigenetic changes. This is, for example, when we go from an undeveloped country to a developed country. In Africa, they have genes that are more prone to store and accumulate energy that comes in because there is not that much available. So when they come to developed countries, they are more prone to obesity because of those genes that accumulate and store everything they eat. We have to differentiate between adipose tissues, the white one and the brown one. The brown one is the healthiest one because it has a lot of mitochondria in it, that's why it's brown, and it helps us with the thermogenesis, the heat creation. The diagnosis of the obesity is using, of course, the body mass index, but it's not enough. So we talked about the waist circumference, body composition, where the fat is also distributed, the comorbidities attached to the obesity. We have to evaluate the concomitant medication and the stigmata of classical endocrinopathy or obesity plus osteoporosis. And we have to do a study of it. Anti-diabetic weight gaining drugs are, for example, insulin and sulfonylureas and glitazones. We also have the GLP-1 incretins, and these are basically anorexigenic drugs which are going to decrease the hunger levels because these act like glucagon. Indeed, they are called glucagon-like peptide 1, and they delay the hunger. Fatty liver has a high probability of heart attack. Analytical triglycerides are most responsive to dietary treatment, and we have to check the albumin-creatinine ratio because if it is too high, over 30, it is pathological, and it is a marker for cardiovascular risk. And we always have to ask for this albumin-creatinine ratio in obese people. And now the treatment. Two phases mainly. The first one is the initial weight loss, which lasts for 6 months. And the second one is the maintenance of the lost weight. So since these are the main factors of the occurrence of obesity, we're going to act on them, the ones we can. At a pharmaceutical level, well, pharmaceuticals do not work on their own, not funded, and they had safety and efficacy doubts. Not with the current ones though. There are some drugs that are coming soon called dual or triple agonist drugs based on incretins, the Mounjaro GLP-1, which are very powerful anorexigenic drugs. We also have the liraglutide, Saxenda, or the semaglutide, Ozempic. And Ozempic has become famous because of the Kardashians taking it for weight loss. But indeed, these drugs are not meant to be taken without a clinical condition. Then another thing we can act on is the diet, of course. The majority of the times they give to these people hypocaloric diets, mixed diets, or very low calorie diets. You have to know that there is no gold standard macros distribution because every diet can work. Indeed, we have several diets here. The Mediterranean diet using Predimed can work for treating diabetes. The DASH diet for the hypertension can also treat diabetes, apparently. Meal replacement shakes can work in some individuals, and mainly the keto diets. Keto diets such as Atkins, Pronocal, and Duncan improve the fat loss. Indeed, keto diets and intermittent fasting improve fat loss by keeping insulin low, because when we have low insulin, we can trigger the fat loss. The lipolysis is inhibited because of insulin. Also, the microbiota in obesity tends to have more firmicutes and less bacteroidetes. And to change the microbiota, we have to provide probiotics, the microorganisms, and prebiotics, the ingredients for the microorganisms' growth. The ingredients they can ferment to grow. And now let's take a look at the bariatric surgery as a third remedy. It reduces comorbidities, it reduces the use of drugs, and it improves the life expectancy. It is recommended for people that have a BMI over 40 or a BMI over 35 with comorbidities. We have two techniques here: the restrictive techniques, which are based on the early satiety, and the mixed techniques, which also add the malabsorption. So the restrictives are the sleeve gastroplasty, the gastric banding, the gastric fundus ring, and the vertical gastroplasty. And the mixed techniques are the gastric bypass and the bile pancreatic diversion. The perioperative mortality is very low, it's a maximum of 1%, and the percentage of overweight lost at 5 years after the surgery tends to be from 30 to 50% of the total weight, so it's very effective. There are also some invasive methods that apparently they do not work though, so the bariatric surgery is better than these. After surgery, we have to provide an adaptive liquid diet, then a progressive diet. So liquid, semi-liquid, semi-solid, solid, progressive. We also have to take a look at intolerances, because we can develop an intolerance to certain foods. There is more difficult in digestion, of course. For example, red meat is hard to digest, and we can create a little intolerance there. And we have to provide a vitamin supplementation 6 months up to 1.5 years, because our gastrointestinal tube has to readapt itself, and it's not very great at digesting and absorbing everything as before. So vitamins supplementation is essential. Control also the vitamin B12, vitamin B9, very important for the gene expression, calcium in the postmenopause women, and iron in the premenopause women. Okay, that's it for this video. I hope you enjoyed it. Remember to download this diagram by clicking the first link in the description down below. Like, subscribe, and turn on the notifications so you get notified every time I upload a new video. Thank you so much for watching, and I will see you in the next one. Ciao!